I imagine you've all had cases where you knew that was, but they just weren't. They weren't going to participate in anything more than what they were at the hospital for. It's like, fix my broken arm or fix this and send me on my way. Yeah.
Yeah. How did it happen? I fell. Kind of thing, like, where they're not giving you like probably the true story of what happened, because I'm processing your, the 7 domestic violence events, and then over what period of time has those 7 events occurred, and to what significance, and obviously the worst being, was it death, or what was it, a broken arm, to what extreme was that patient injured or victim assaulted, so that's mind-blowing that it's at 3%.
It is. That's sad.
Absolutely crazy low. I think you hit the nail on the head there. That's just boggling to me on how low that number is. And I agree with you. We obviously all got into this field to help people. We want to save people and encourage them, and that's probably something that's very hard on the provider and the but nurse, paramedic, physician, is you have that patient where it's like, yeah, we can help you. We have these resources to help you. And they're like, kind of like you said it, I just want to fix my broken arm and I want to leave. And there's a lot more to that story. God forbid you see that repeat patient, then again, that's injured, that plays on us or weighs on us as obviously providers too. That's wild.
And it's different when there's somebody else involved, right? It's a different story if that's COPD or at home that somebody called because they were short of breath. You're like, the 5th time I've been here, man. Yeah. All I want is, all I want is the steroid and the albuterol and go away. Yeah. And that patient is making the choice for themselves, but you have this other person that's, that is contributory to that factor it's a completely different set of circumstances.
It's out of their hands. And that's where the consent comes into being a critical factor. You want them to have autonomy. They have not had control of their lives, to control their decisions for who knows how long. So that's why it's so important. Even though they don't want to leave, it's still in their hands and their choice.
Right.
Yeah.
Mm-hmm. And I think, something for our EMS providers, I think a lot of the times, people don't disclose for various reasons. A lot of times you're going to get those calls for, abdominal pain or some other chief complaint that's not, I was assaulted, or it's totally ambiguous, But then, you guys will start to pick up on, repeat offenders, right? Like patients that you respond to the same house over and over again. I think, having an awareness of your surroundings, kind of like, having that heightened sense of awareness. What does the scene look like? What do the children or pets look like in the home? And then if you do have that suspicion, it's okay to, ask those direct questions like, did someone hurt you?
Hurt you, yeah.
Yeah, and, totally in a non-judgmental way, but, offer that opportunity, that chance for someone to say yes, or I need help,
I think you bring up a great point is, the one side that we might see that maybe you don't see from the emergency room is we get to see their residents. We get to see. So let's kind of go down your. If I go on a rant here, I'm sorry, but let's go down your broken arm, right? Yeah. We go to the house. They dispatch us for a broken arm. I'm like, okay, it's a broken arm. I can do some pain control. I can splint it. That's what goes through my mind initially. How'd they break their arm's going to cross my mind too.
Right.
And then you get there, and then you have that awkward tension, or maybe the husband is answering for the wife, where it's like, I want to ask her a question. I didn't, like in my mind, that's what pops up. Like, if you don't allow her to speak, and things of that nature. And I think that's a great point is, on the EMS side of things, it's pretty easy for us to split people up then. That's the way I see
Absolutely.
it. Okay.
Yeah.
Well, tell you what, and kids and dogs are great. I use that as an out all the time. Be like, hey, I'm going to let you get the dog out. And then we're going to take her to the ambulance.
Yes.
And then I could separate them. And that's when we can have that conversation. Hey, you're safe here. I always want to make that known. You're safe in our ambulance. We will protect you to no end, or law enforcement will as well. And, is there anything else you want to tell us? Because, you falling down the stairs, breaking your arm doesn't make sense to me when,
Right.
you know, we met in the garage or whatever the scenario may be, is we can start to pick apart those little pieces where this story doesn't make sense. And you can maybe see the tension in between the two individuals, where you have a heightened sense of, you know, intuition, if you will, for, you know,
Right.
is this person, a victim of domestic violence? You know, could you pick up on some of those cues? And yeah, I think that's great. You know, get them into your ambulance, try to split them up, and then you can have that question. And you know, I think you bring up a great point of just be direct. You know, is there anything you want to tell me? Is there, you know, how did you really break your arm this way? You know, it's okay to tell. You know, we just want to know the truth. We want to help you. You can kind of pull it out of them, and then see it's their choice to offer it at that point. But, you know, and then documentation comes into play for us and things of that nature as well. Plus the handoff's different then, and law enforcement involvement's different then. But no, I think you bring up very, very valid points that you don't want to miss those cues of things in the home that we might get to see that other people don't.
That's the advantage we have in this mix here is we saw where it originated, right? I think all healthcare providers very quickly, you know, in their evolution as a provider, get a pretty good bullshit meter, right? And we have the advantage of not only having, you know, said meter, but also like putting that in context of what's going on when we walk in somebody's house, and you know, like you said. You can walk in the door and smell it and be like, nah, something's wrong here.
Totally. And even if they don't want to disclose, right, we can just offer the opportunity. It's not our job to like force them or, you know, try to make them feel bad or pressure it out of them. But then the most important piece is like document their injuries, document any inconsistencies. You know, and a lot of times I think quotes are really powerful, you know, things that you heard.
If they spontaneously.
If they said this,
just, I think that's so important, you know, and then just anything that you observed in the home, any statements told by, you know, both parties, that can be helpful to the patient later on down the line.
And I like what you said
even if it's
there.
Conflicting, right?
And I like what you said there too. It's we might offer that, and we have that. Maybe let's say we have 5 minutes alone, and then the other forceful party is like, "Well, I want to ride with you in the ambulance." You know, that's always kind of a red flag for me.
Sure.
It's one thing when, you know, it's a sweet geriatric patient, you know, and it's night, and I don't like to drive in the dark, and you know, they're 80 or 85 years old. I totally get it, you know, but when they're 30, it doesn't make sense to me, or 35.
It's all
like,
context.
It's kind of a red flag to me,
It's
like
all
why you can't drive your car to the hospital. So when we have that time, we can offer it, but don't pressure it, because maybe we've put that idea into their head, and then at least when they get to you or at the receiving facility, and you have that break, maybe they would per se respond better to a woman than a male provider. Maybe they don't feel comfortable talking to one of us, or we don't have a female. I'm just throwing that out there in the scenario. But maybe they don't feel as comfortable talking if it was a female victim talking to a male provider. And then now that, let's say we're at the hospital and there is a female provider, maybe a female would speak better to another female or open up. But at least we've given that, like, hey, you know, this is where you're in this safe space. We're taking you to another safe space, and that's okay if you don't want to tell me anything. And, you know, if that changes, then, you know, tell your nurse or tell the physician at the receiving facility, it's, you know, it's okay, but we're here to help you. That's all we really want you to know. And document well.
The other wild card there is you don't know who is going to be comfortable with whom. I mean, everybody in this room, I don't even have to ask, I know, has had the experience where a patient tells you one thing and then you try to escalate it to, you know, to somebody else, and they won't tell them about it. I'm like, well, you just told me this story. You know, what is... so you shouldn't get in the mindset of, they're only going to talk to the nurse or the doctor or, you know, although we most of the time in EMS get you'll ask them the question 9 times, 4 different ways, and then the second the doc walks in, they give you, I'm just like, damn it, man. But we've also had those other cases where, things have been disclosed to us, and then they're reticent to talk about them when they get to the hospital with nurse, with doc, whomever, right? And then again, we need the Ferroni in here pounding the advocacy table, but it's what it's about, right?
And I mean, that was just my scenario, not to undercredit like a male victim or a female victim for. Sure. I just want to loop back to that so we have clarity, but we were kind of just running with the same scenario on that.
So you guys mentioned that you go into a place and your instincts, your spidey senses are going. You know something's off. Yeah. And the person's harmed. They're physically harmed and need medical attention, and they decline to go with you. And they sign the form.
It's a great point. It's so great. I just typed it there. I just typed it there to make sure we hit it.
I didn't even read that.
I did. Yeah.
Neither do I. I don't even look at the script. It's just easier.
So what happens? What do you do?
So we can.
That was going to be my question to you. Why are you asking me?
Because I want to know what you guys do.
Do you want to elaborate? You want me to?
So I would hope. Part of the sign-off process, we've kind of teased it out for dangerous sign-offs and typical sign-offs, I guess, if you will, with no risk. So, although like sexual assault, domestic violence really isn't even on that matrix for us, and that was one of our educational pieces that Dr. Spanner put out last year, I can't remember, but we'd gone down, and basically all the super dangerous stuff is going to come back to bite you in the ass. The syncopes, the tachyarrhythmia, stuff like that. That, okay, you're sick. There's something going on here. You have a high risk of. But we really never, in that whole sign-off thing, talked much about that. I guess it would be kind of just in that same concept of showed up on an MVA with a trauma. It would probably inappropriately get lumped into that whole kind of same thought process. It was, it's a traumatic injury, patient doesn't want. We would do the sign off. We would, give them, as part of protocol, we would, give them the what could happens, right, and let them make a educated decision, right, some educated consent, right, informed consent, and that would be it in most cases. I think in most cases. So now let's talk about best practice. Like, what else can we do? How do we make that safer for the patient?
I can't speak to like EMS specifics because I'm not totally knowledgeable about your whole role. But so they're signing the form, and sometimes you can just ask them, "Are you okay?" And they might give you a little pieces of something, and something's off. And would you encourage them to contact law enforcement?
So I think a lot of times it doesn't, I don't think this happens a lot of times. Let me rephrase that. But I think if we get into the situation where it's gray, at least I can speak for my department and our staff. A lot of times if it's gray, one guy will walk outside and have the PD come. Not lights and sirens. So a lot of times, we've gotten somewhere and we're like, this is just sketchy. Even if they don't want to go, it's just sketchy, and a law enforcement officer shows up. And then usually that sparks a conversation, right, between the two people in the residence. So I don't choose male or female. So
Two people in the residence.
What
are they doing here?
What are they doing here?
Yeah, no, that's the automatic trigger.
That's the trigger. Why are they here? Did you call them? No, they just actually come to a lot of our ambulance calls with us just to make sure we're safe. Yeah. And they just check in. It's pretty normal. They were just right down the road and they just swing in. So we casually blow it off so that they might just be standing back there saying nothing, but they're watching the whole thing too. So I think that's one of the things that, and I'm sure a lot of other fire departments do that as well. When you get in there and you just have this heightened sense of the story doesn't add up, this doesn't make sense, I'd really like to take you to the hospital even though they don't want to. A lot of times I think we should always encourage, invite law enforcement. And it's pretty easy for us to play it off while they're there. The world is definitely a crazy place, and for a multitude of reasons. So it's okay to just say, oh, well, they go to a lot of
ambulance calls.
They come with us all the time just to check out, make sure we're okay. Sometimes they help us, and it's casual, just blow it off. So I think that's a good way to bring them into the situation. And then maybe something else will come out of that. Maybe the patient will feel more comfortable. Not saying that would happen every time, but hey, if it happens once, then it's worth it. And then I think our other outlet too is if a patient really does not want to go to the hospital, we can always call medical direction. We encourage that on every single
else.
podcast that we do. It doesn't matter what we talk about. If you have that patient that really doesn't want to go, and that provider feels very strongly about it, you can call medical control. It's a recorded line. Maybe they need to hear from somebody else.
Yeah,
hey, I can put you on the phone with the physician.
Right.
You can. I'll hand the patient the phone and say, hey, why don't you just talk to the physician for a minute?
You don't want to hear it from the dumb paramedic.
We usually give a rundown really quick to the physician, but it's like, I really need you to talk to this patient because they need to come to the hospital. Maybe that can turn the patient's maybe that can turn the patient's mindset of, okay, like, they might not say what's wrong, but maybe even the encouragement from the physician of, let the ambulance take care of you. Let them bring you to us. It's okay. You're hurt. They want to help you. Like, we'll figure it out. Just come here. And I think that changes the patient's mindset. Those are a couple tools in the toolbox that I can think of.
Those are some things that change the scene dynamics. Absolutely.
Yeah, 100%. And it's a recorded line. It's a documented conversation. So if we ever needed that in the event of something, it wasn't just like, hey, sign here. You don't want to go to the hospital. See you.
Right.
We're out. I think that is extra steps by providers to really encourage that, to get them to come to the hospital.
That getting the law enforcement there also makes that situation known to law enforcement, so it's not just in our silo.
Correct.
So when the next thing happens, they're like, yeah, we were on a scene with them last week, and there was something, now that, strengthens.
Right.
Maybe not that case, but
they're on the radar.
They're on the radar for the next one. I like that.
I think another tool too that maybe after this podcast people will do, but have something like a national DP hotline number or something that you can discreetly provide to the patient. We have
they can text, like a number they can text. Because we just sat through a mental health symposium yesterday for 8 hours, some of my staff and myself, and one of the nurses, who's a friend of mine, he was sitting in there, and he actually brought up your point of, he goes, I get this patient into the emergency room, and it was for like abdominal pain, and they're going down, and it's like, he's like, I get to this part where it's like, do you want to hurt? Do you feel safe at home? And then it's like crickets, and he's like, well, I asked 4 or 5 or 6 questions already, and you're like, yes, no, it's been going on for an hour, my pain's an 8, and it's like, okay, do you feel safe at home? And he's like, nothing. Then I look at the patient,
I heard no, right?
Am I missing something here? Are you just here for abdominal pain? Is there anything you want to tell me, like you're safe, and granted, it was about mental health more so than what we're talking about today, but those two could probably go hand in hand in what we're talking about today.
Absolutely.
But you're catching it on that loop, so when we're doing a good assessment, and really communicating with our patient, maybe they'd open up more. And then we talked a lot about, the ability to text now. So if that person is in that unsafe situation, maybe handing them a card, hey, if you text whatever the number may be, I need help, or this and that, law enforcement can ping their cell phone, or they can give them the address, and then boom, 3 law enforcement officers show up with the ambulance, and it's like that person's safe because they want to seek help. So I think that's a good tidbit. I mean, we do a lot of this stuff with Leave Behind Narcan kits. We do all this. We do all these other things
in these other spaces, right?
Yeah, we do all these other things. There's mental health numbers you could text. There's just, I really like that.
And you're giving that patient the autonomy, right? We talked about that earlier, right? Giving them the power to know when, they're ready to seek help.
So when someone comes in and they decline, it's domestic violence, and they decline services from the SANE. I mean, it's great they're there to get their medical, so at least medical. But then the safety. We have a 5-question danger assessment. So you don't want our services, and that's okay. But can I just ask you 5 questions?
Okay.
And then you do the 5 questions, and then you tell them what their score is, and it impacts them a little bit.
Sure.
But it may not, it may like they're all in and all of a sudden they want your services, but you're going to plant the seed that they're in danger.
Yeah, that makes sense, right? Is if you're not going to do it now, let me at least
let me lay this out.
Set the circumstances up for you to,
And then we also, for people that don't want to leave, again, for different, like he's got warrants for his arrest, he'll go to jail, then I won't be able to buy my kids groceries.
Sure.
So they've got these reasons, and they're valid reasons.
Yeah.
And plus they're scared he's going to kill them. We have little cards that have the phone numbers that they can call for help, that they can tuck in their shoe or tuck wherever. So you guys could carry those too.
Yeah, we could definitely distribute those to our. Yeah, we could definitely distribute those to all the ambulances under our medical direction and share that, so that gives them another outlet.
Yes.
Right.
And the other thing
tool,
too, not to circle back to something else, but it just made me think of it as consistency with going back to the residents. One of the benefits of technology in our world is we have MDTs in every truck. So when you get dispatched to the address and you're looking at it, it gives you the cross streets, and then it'll also give you a call history. So we've been here 10 times before.
Wow. Yeah.
So you can literally touch the button, open up the call. So for some of the departments that are listening, if they have MDT capabilities or if they're in their rig, you can actually pull those up. It'll give me the date we were there, the time we were there. I can actually go back into our archives and look and see. I could pull every computer-aided dispatch up. What did they call for? You know, broken arm, fell down the stairs, this and that. It's like, well, we're coming. I have 10 plus calls to this residence, and it doesn't make sense.
In some cases, that'll be mixed police and fire EMS response.
Correct.
So you'll see, you know, there was, okay, cops have been here 3 times. I've been here 7 times. All right, there's clearly a pattern.
Yeah, and they have their records as well. So they might just randomly show up because they see, just repeat calls to the same address. This doesn't make sense.
Gets flagged. Yeah.
So some of those things that are in our setting, we need to utilize as well.
All right. So the DA5 questions. Has the physical violence increased in severity or frequency over the past year? Has your partner or ex ever used a weapon against you or threatened you with a weapon? Do you believe your partner or ex is capable of killing you?
That's a big one.
Has your partner or ex ever tried to choke or strangle you or cut off your breathing? And is your partner or ex violently and constantly jealous of you? Are the 5 questions for the danger assessment.
It's simple, basic, but it definitely identifies the lethality of their situation.
Sure. And then the documentation piece. All right, what should we be documenting? What do you need out of our PCR, if our patient care report? If we're bringing somebody in and we suspect DV or we suspect a sexual assault situation, what's helpful to you? You mentioned quotations.
Oh, yeah.
Putting, spontaneously said things in quotation marks, right? Mm-hmm. Anything else that's helpful?
Maybe if they report strangulation.
Okay.
Choking. They call it choking.
Yeah, sure. All right.
Okay.
Fair enough.
Any type of physical wounds we see, obviously, we should just say we found, various types of bruising and different stages of healing.
Any inconsistencies in the story, what the scene looked like, things that you may have heard the patient say or anyone else in the house say. Okay. All that, documenting those type of things is helpful.
Condition of the environment.
Yeah.
We're generally good about that. I think departments are generally good about, condition of the living situation if it is applicable to the case, right? Mm-hmm. So, all right. And are there any statistics on the male versus female sexual assault piece? I mean, you said that
males do get sexually assaulted,
right? Yeah,
and we do those cases as well.
Yeah,
but I don't know if it's ego driven or what the reason, but males don't report.
Even
sexual assault.
Even less than that 3% average,
right,
I assume.
Right.
Yeah. Okay.
Now, for domestic violence, though, for Ohio, for 2022, there were more reported male victims of domestic violence than females.
Really? Mm-hmm. For 22. Mm-hmm. From our perspective, do I need to make decisions on where I'm transporting this patient to? Right. So I guess let's tease that out into 2 different scenarios. Right. One is major trauma. I have a trauma center close. Probably, let's say they don't have sane capabilities, right? I think that's pretty self-explanatory. We talked about that earlier.
Medical first.
Medical first, yes. Right? The standard protocols for that. But let's say it's, patient meets us at the door. They're walking, they're talking, they're otherwise stable, has injuries. All right. Now that knowledge we tease out that in fact this is DV. Yeah, this is in fact sexual assault. what transport considerations do I have? Should I go somewhere where there is sexual assault nursing? Are they going to come to the hospital? How does that get mixed up?
Mm-hmm. I mean, best practice would be, if it's a sexual assault or intimate partner violence case or situation, for them to be seen by a sane nurse would be ideal. I think Maine campus, Maine always pretty much has consistent sane
Coverage, huh?
coverage.
Okay.
Yeah. I think it's variable at some of the community hospitals. Being out in this area, I think our Portage, Portage is pretty consistent with having sane response. But, they can always see a sane nurse, but that patient, once they're seen, cleared by the physician, if they do want to see the sane nurse and there's not one available to see them on site, they might get transferred to the closest hospital that has sane coverage.
Okay.
Mm-hmm.
So if I was equidistant and I knew one didn't have, obviously I'd make the choice to take them to the one that I knew had more availability, right? In that same realm, is it appropriate for me to call ahead and say, do you have coverage?
Yeah, I think so.
Yeah.
And sometimes, we get cases, patients might not want to see the sane nurse,
Right.
might not want to, have a forensic evaluation.
Just because we identify doesn't mean that
so
they're
just because
gonna
it's
get,
identified doesn't necessarily mean that that patient wants to be, have a sane exam.
Understood.
So, that's maybe a conversation you could have with the patient as well to help further figure out where you might want to transport them to.
And let's build off that. I say, hey, there's this, you kind of qualify for this. You've asked for the help. We want to get you to this resource. Can we, should we in the report, in our phone report, say, hey, explicitly say that we need the sane resource? Or is that something like when we get to the hospital, then, hey, doc, let me tell you a story about what's going on here, and we need, that they want this help. Is that pre-notification helpful or is unnecessary?
Like if you suspect it, but the patient didn't disclose.
Let's say they disclosed and they wanted the help, and I said, hey, I want to get you to this resource. I want to get you to the sane resource, right? Is calling that from the field helpful to your mobilization, or does it really not matter in the timeline of things? Mm-hmm. We're used to calling STEMIs and strokes and sepsis alerts from the field, right? I don't want to put it exactly in that category, but still pre-notifications, like get the ball rolling.
Yeah, and Scott and I talked about this off camera, and this was actually one of my questions that I had, is because, we teach so much to take the right patient to the right place. So if it's if it's a trauma patient, we know the trauma centers, whether it's a level 3 in the community or I'm going to go to a level 1, or if they need to go to a burn center. We know our stroke capabilities. We know all of these things. Yep. So, I think what Scott's kind of trying to elaborate on is if I'm sitting in, let's say, I'll just make it easy. I'm sitting in between Portage and Geauga, and I'm right in the middle on 44. I could go north or I could go south. And I have that patient that has expressed that they have been sexually assaulted. We explain, hey, this is, they have specific sexual assault nurses that could see you, and they're going to do a special exam. Mm-hmm. I have no issue as a provider calling Portage and saying, I have a sexual assault patient that has openly admitted that and wants to, see a sane nurse. Do you have that resource, or should I call Geauga? And I know as an emergency room, obviously you're not allowed to refuse a patient, and I think that's good. We kind of maybe discuss that a little bit so providers understand, like, they're not telling you no, don't bring the patient here,
right?
But we want to get them to the appropriate resource. Because I know when we call and they're like, well, I can't tell you no, and it's like, no, I fully understand that.
Right.
I just want to see, is this patient better served if I bring him to Portage, because maybe it's your coverage day, and you can secure that resource that being you, to assist that patient, or maybe even better served taking that patient to Geauga, was kind of where I was going with that. You know, because if I could avoid that patient transfer, I know it's going to happen. It's not a perfect world. We're definitely going to transfer patients still, but if we could try to avoid it, I guess that's kind of what we're looking at.
Yeah, definitely. So, I mean, in that situation, definitely, I think probably calling ahead to see like where the resources are is probably going to be helpful.
Okay.
And our goal, like as our unit and our team, we're trying to train nurses to have the services and all the EDs, so nobody has to be transferred anywhere. That's what we're building right now. We're just not there yet.
And we fully understand that, and especially now that you've explained all the clinicals and all the in-depth education that goes into it, we fully understand that.
It's not
it's not an overnight thing.
It's not you're blessed this, we have this capability, right?
And you're trained.
And be great. Yeah, it doesn't work like that. Anything in medicine doesn't work like that.
So,
sorry.
No, go ahead. So we can just encourage the providers to, maybe make that phone call. I understand that your emergency room is not refusing the patient. I'm just saying, hey, would my patient be best served if I brought them to your facility, or if I have another facility option, like I could go to Ahuja.
Right.
Like I have no issue.
That's no different. We've got hospitals that are that can do thrombectomies.
Yeah.
When somebody's there, it's not inappropriate for me to call up and be like, "Hey, this guy qualifies for an LVO.
Yep.
Are you able, or do I need to make a?" That's again patient advocacy. That's getting them to the right spot, right? That's not wrong, and they're not refusing if they say no. Right? We're all doing the right thing for the patient, and in that, it overlays that. It's just a different, on a different scale, right?
Yeah.
Well, I was you were going to say something.
Sorry.
So if someone reports being sexually assaulted, and there's a couple little parameters, like did they have capacity to consent? Was it within the last 96 hours? As far as like evidence collection, they still need services though.
Sure.
So are you saying you could like call the transfer center and find out where there is SANE?
I doubt the transfer center would have those optics, but let's say, I'm a municipal department. I've probably got 1 or 2 or 3 different hospitals I would transport to on the routine, right? One, I think hopefully this is bringing the awareness that I need to know who has this service and when, right?
Yeah.
And that's something they should reach out to their EMS coordinators to have that conversation with, right? And then subsequently, if I know, and you just, in this conversation here, say, all right, he used Portage and Geauga, because you said Portage seems to have more coverage currently. Obviously, you're building that out, and it's going to, hopefully be, equal across the system at some point. But, do I make a left turn or a right turn to get them to the appropriate resources? EMS is very accustomed to that mindset. I mean, we honk and wave at non-trauma centers, and as we're going to the trauma center, right? That's it's second nature to us, and we know, of course, when to say, no, there's airway compromise. No, there's another reason I need to stop and get help at the local center rather than going to the trauma center. That's pretty intuitive to what we do. So I don't know the transfer center would have the. Having worked up there for the last week, I can tell you they don't have the optics on that.
Wait, on SANE coverage?
Yeah, do they?
Yes,
they do.
Yes.
Oh, I have seen a lot of documentation up there. I have not seen anything on SANE.
That's coming in week 2. Week 2, you'll get it.
I'm going to be back there. I'm going to be back there tomorrow, and I am going to definitely go look for this to see if they have that.
I think one of the things we would probably do as an EMS provider in that situation, if I have, let's say, 2 hospitals as my option, I'm going to call the first one that I think is most likely going to have that resource, and say, okay, if you don't, I might call the other one and check. I think it's just 2 quick phone calls. I have this patient that has been sexually assaulted. I'm looking for this resource. Do you have it?
Right.
If not, I'm going to call the other facility. And sometimes, too, as providers, we might have to explain to that patient, maybe I'm a Geauga patient, and I always go to Geauga, and I'm just using this as an example. But hey, that resource you really need is at Portage. So, they're going to have your medical record. It's still going to be okay. You're still going to see UH physicians. You're still going to see UH nurses. We're still keeping you in network. It's just that resource that you need's down there. So I think in our world, it would probably be like a quick phone call or a quick, to like Dr. Hill or whoever's working in the emergency room. and just ask that simple question.
Yeah.
You know, am I better served taking my patient here? Here, just give me a heads up.
I think
all.
that's a good practice.
For another point from the pre-hospital provider mindset, right? The first hospital you call doesn't necessarily have to be the hospital you go to, right?
Correct.
It's not a one-call thing.
Yeah.
Yeah.
And I think it's like, I only can call the hospital I'm going to. No.
Nah.
I mean, my personal experience was I had a patient that needed dialyzed. I mean, this was not even, this is like second day paramedic school stuff. Somebody could figure this stuff out, right? They need emergently dialyzed. This was not a secret, right? The closest hospital, I'm like, I don't think they can emergently dialyze. So I simply called them, right? And I said, hey, can you, I know what this patient ultimately is going to need. Here's what we've done so far, right? And they're like, no, we can't. I said, all right, I'm going to drive 5 more minutes to another center to get this patient appropriate care. So again, it's very intuitive. But that first call, I didn't lock myself into going to that unnamed hospital. By making that phone call.
I think we're pretty used to that.
Yeah.
Because our obvious goal is we want to help them. We want to get them to the resource they need. Or whatever specialty they might need. Maybe that would be a better way to say it.
Sure.
Right.
So.
Yep.